to come along and talk to us about digital health. And digital health, and it was such an interesting presentation, we asked him to come and do it here as well to share it with all of you. You know, digital health is one of the most exciting areas to emerge with significant opportunities, not only for health services but for well-being of everyone. In developing nations and developing economies, it's become critical to even provide the most basic health care out into the villages, etc. So it also gives a lot of interesting business opportunities, but we don't quite understand how they work sometimes. So our final keynote presenter, as I said, was so well received in Nice that we asked him to come along. Now, for an engaging and very entertaining look, trust me it will be, at the world of digital medicine, please let me introduce to you the VP and Chief Medical Information Officer from the Phoenix Children's Hospital, Dr. Vinay Vaidya. Dr. Vinay, welcome. Here he is. Good to see you again.
Wonderful.
Good to see you.
Good morning, folks. I must apologize because I'm standing between you and lunch. But I must say I'm delighted to be here and share with you some of the exciting things that are happening in the healthcare industry, and perhaps also share with you some of the areas where we are lagging behind other industries where we might learn from you. This is where I work. This is Phoenix Children's Hospital. We are about 4 hours south of the Grand Canyon. Isn't that beautiful? It's a great time of the year to visit, so we are the adjoining state. Come on over. As you can see, we are a relatively new hospital. We are just 30 years old. Some of the hospitals I've worked previously, University of Maryland, was about 200 years old. DC Children's was 125 years old. But even with a relatively new hospital, with more than 360 beds, it places us amongst the top 3 or 4 children's hospitals in the country. What you see up there on the slide, on the top row, is some of the accolades that we have received. But to us, what is more important is the accolades at the bottom of the picture. These are the smiling children that we want to cure and send home from a hospital smiling. Each hospital has different areas. And this is the pediatric intensive care unit. This is where I spent the early part of my career, 15 years, taking care of kids battling life and death situations, saving most, but not all. And then I realized the lack of information technology in all that we did on a day-to-day basis. The difficulty, the task going through data, the copying, the handwriting, and I realized the power of information technology, and I moved over to clinical IT. At heart, I'm still a dumb physician surrounded by smart folks like you. So as you look at digital disruption occurring in the healthcare industry, this is perhaps one of the last frontiers for the digital wave to hit. And I'm not talking of this disruption. The website is still down, and aren't we in the heart of Silicon Valley over here, and surrounded? I think the big boys should have helped. You know, the Googles and the Facebook should have helped with this website. Or I think what would have been a better idea, we should have all outsourced it to India, and it would, it would have worked well. But so this is not the digital disruption I'm talking about. I put this slide up to give a time perspective. From the very beginning of time until about 100 years ago, most of what was practiced as medicine really did more harm than good. I'm going to show you a couple of examples. So that's George Washington lying in his deathbed. He died 1799. And what started out with a simple throat infection, a strep throat, it developed into an abscess that is called quinsy. And in those days, the treatment for most ailments was bloodletting. Over the period of 2 days, he had almost 3.5 liters of blood removed from him. And we don't know this for sure, but it is postulated that he probably died of hemorrhage or bloodletting rather than the tonsillar infection. The slide on your left, that's the bullet wound in Lincoln's head. And what you see above that is the bone fragments. That's at the National Museum of Health in DC. And can you see the long probe there? That was a porcelain tip probe that was used to probe the bullet wound to try and remove the bullet. Again, we don't know for sure, but some say that perhaps the probing caused more damage than the bullet, and that could have resulted in his condition worsening. And on the right, you see, this happened in Arizona, in Tucson. Gabby Giffords was nearly fatally shot, and she was rushed to the university hospital. The bullet passed through her head. And look at the picture on the bottom. That is her outcome and what we are dealing in 2011. So even not more, just about 113 years ago, this is where medicine was. Now, can any of you read what is there, written over there? Well, it's doctor's handwriting, right? So you can't read that. But let me translate to you. This was a death certificate from 1900, and the cause of death was found dead by visitation of God. It was a cause of death in 1900. And look where we have come in the last 100 years. That's a marvel. That's a mechanical marvel of a knee, complete total replacement of knee. But it's still a joint. It's still a machine. It's still fabrication. Look at this. This is artificial ear. This is a microphone, a radio transmitter, a computer chip implanted in the inner ear, picking up signals and sending them to the brain. And this is in development, the artificial eye, a nano forceps placing a small light-sensitive retinal chip to give light detection to those who are blind. This is actually creating synthetic DNA. Look at the arrow there. And in the small print, it says you really can order segments of DNA from a mail order catalog. They are put together in a bacteria. The bacteria stitches it together, and you get synthetic DNA. This is the last 100 years. So we have moved quite significantly, but it's not without challenges. Maybe there are opportunities in healthcare. And these, I would say, fall in 4 major areas: the access to healthcare, the costs, the quality that we get for what we pay, and the use of technology or the lack of use of technology. So this map shows the availability of physicians per 10,000 population. You can see Norway up there with 41 physicians. USA is about 40% less with about 24 physicians. India is 3 times less with 7. And some of the African countries, it's really non-existent, less than 1 physician. The WHO estimates a shortage in about 2006 of almost 4.5 million physicians. And even developed countries like US are not exempt from this. The American Medical Association estimates about 65,000 shortage of 65,000 physicians by the year 2015. And in the next 10 years, that would double to 130,000. The population is aging, people are living longer, and physicians are retiring. So that mismatch is causing that lack of access. This was the US healthcare spending, public, private, everything put together, in 2009. That's 2.5 trillion, not million, not billion, but trillion. Sometimes it's hard to grasp the concept as we quickly use terms from million, billion, and trillion. To put things into perspective, 1 million seconds is 11 days. Make it 1 billion seconds, that's 31 years. 11 days to 31 years. Make it 1 trillion seconds, that's 31,000 years. Make it 2.5 trillion, that is somewhere around the time when Neanderthal man was there. So it gives you the concept of the amount of money that is being spent on healthcare. Obviously, Warren Buffett is not happy. He says this is like a tapeworm. You really cannot compete in the global market when your employers are paying this kind of money for health insurance. It's like a tapeworm eating into our economy. And this is another way of looking at it, how much we are spending. So as you can notice, this is healthcare spending expressed as a percentage of GDP. And USA is up there with 17%. It started with the pack 6 to 8%, but quickly diverged from the other developed countries, mind you. And we are spending almost twice as much as most other countries. This is a busy slide. But what it shows is 7 developed countries, and it is measuring healthcare performance across various of the parameters over here on the left. On a scale of 1 to 7, 1 is excellent, 7 is the lowest. And you can look at US, 6, 7, 5, 6, 7. Netherlands comes in the first position in spite of spending almost half as much as the US. And then if you look at the technology adoption in various countries, USA is on your left in the brown color, and the percentage of use of electronic medical records was just about 46 to 50%. Compare that with the rank first and second countries, the Netherlands, other European countries, the rate is much more than 90%. Cannot associate directly, but there's something to be said with the lack of technology up to 2009. Look what happened in 2009, though. The stimulus bill, also known as the ARRA, the American Recovery and Reinvestment Act, pumped a large amount of money in the economy. And then of this, almost 20 billion was earmarked for the High-Tech Act. And what the High-Tech Act was, it was nothing but to put it simply, it was cash for clunkers. You remember the cash for clunkers program? Give us your old car and buy a new, better car. This was give us your paper system, give us your legacy system, give us your EMRs that are not talking to each other, and use electronic medical records that have been certified to operate in a standard manner with standard nomenclature, and use it in a meaningful manner. Collect data that is important for safety, quality, efficiency, and patient education. So this was an unprecedented financial boost. And here you can see in this slide, almost $15 billion from 2011 to 2013 have been paid to more than 4,000 hospitals and 300,000 physicians who took part in getting rid of their old technology or paper-based medication administration and medical records and moving to the new world of electronic medical records. It gave a big boost to the industry, 50,000 new jobs, new vendors, new products in the market. It even addressed the doctor's jokes, the handwriting, and look at e-prescription went up from 0.8% to 53%. Jokes aside, what you see circled there in the red is a handwritten insulin dose, and the physician has written 8 units, and the U looks like 0, it looks like 80, and 80 units were administered to this patient, a 10 times dosing error. Serious conditions. So other than this boost of the stimulus money, what are the other factors that are driving healthcare technology explosion? And these are some of the areas we'll cover today. We have heard this before, more than 85% of the world's population has access to a mobile signal. There are more mobile phones than people have access to electricity, clean water, or even toothbrushes. I guess you don't need a toothbrush if you can have a eye brush there. The mobile phone has become the conduit between the physicians and the patients. The smartphone physical is bringing up all kinds of devices that interface with the phone, capture the patient's data, move it either wirelessly to the phone, from there to the cloud, from there to the physician, or to the hospitals. What you're seeing is a case on the back of the iPhone, which has a built-in cardiogram. You just hold it up so that the metal connectors connect to your finger, or you can place it on your chest as electrodes, and it measures the EKG wherever you are. Similarly, an eye examination device, a blood pressure measurement device, and this is a wireless device that measures the heart rate, respiratory rate, blood pressure, and oxygen levels. So this was the technology that we used that was all invasive in the ICU where I worked. And this is all non-invasive. It's just sitting on your arm. So this is all that is happening in the area of mobile. These are FDA-approved diagnostic quality radiology images that the radiologists can see and diagnose on the fly. We have talked about sensors everywhere. We just heard a talk from the BMW folks about the connected car. How about the connected human? Sensors in your heel or a strap around your forehead is measuring how deep you're sleeping or lack of sleep and sending it to a central monitor from where it can be uploaded. You can measure blood pressure measures. You can measure continuous blood sugar levels. So it's the connected human being, which is no longer a black box. Look at that. This is not yet FDA approved, but it's a small implantable chip that picks up early chemicals that are released into your blood before a full-blown heart attack develops. It can send the information to your phone, and there's heart attack, there's an app for that too. You could set it to a special ringtone, beeping in. Well, and jokes aside, you would want to know, right? It's time to call 911 or time to. But this is the direction. This is, there's thousands of points of IPs all over your body. So they call it a body area network rather than a local area network. And this is happening. Mobile health is picking up. The markets are huge. The projected markets are in the billions. 80% of physicians and greater have smartphones. So they are adopting this technology much faster than the electronic medical record. We heard about social media, and what we thought in healthcare, that your health information is very private and very personal. It's not amenable to the Facebooks and the Twitter, and it should not be used, and most folks won't use. We were completely wrong. There are numerous sites, and the thirst for information sharing is just like on Facebook or any other social sites. There are patients like me, there is Cure Together, there is Caring Bridges for those who are dying. And you see the peer-to-peer connection between patients who have similar problems is very powerful. So whether physicians liked it or not, this was moving fast. I would not recommend using Facebook to diagnose a condition, but just wanted to show you one thing. What started as a benign-looking rash, look at the red cheeks. And that looks like a benign rash, but it is an early warning symptom of a very serious condition known as Kawasaki's disease that can affect the coronaries in these small children unless it's diagnosed and treated correctly. And the mother went from many pediatricians, and one of her pediatrician friends across a couple of states looked at this rash and said, you should talk to your doctor about Kawasaki. So these are examples of where. This was my hand 3 years ago. I had surgery. I was discharged from the hospital. And one day later, I had severe pain. And I knew that if the blood supply is compromised, I could lose movement of the finger. I could not get in touch with the surgeon. I took this picture, and then I realized a friend of mine who I went to medical school was in Michigan, 1,000 miles away. I sent him the picture. He said, it looks fine, but I'm not sure how well you can move the finger. I made a quick video clip, sent it to him, and got a response back. So I've not even touched about telehealth, but you can see the potential for areas that do not have doctors or rural areas, that technology can really reach out there. The thirst for knowledge, the thirst for sharing is exemplified over here. Caslight is a company whose only model is providing employers and those who pay your insurance data with two things, cost and quality. And guess what? When you measure something, it automatically improves. They have got $180 million in funding for this particular model because the cost information, when you go to a doctor, you have no idea how much you're paying or how much the insurance is charging or what are the fees and what are each individual breakdown item. The government was not far behind this. For the first time in the history of Medicare in about 50 years, the cost data is now being published across all hospitals for comparable procedures. And when you have transparency, look what happens. The same surgical knee replacement from $104,000 at one hospital to $29,000 in other hospital, 350% difference. And of course, you'll say this could be in different states. It could be in California right here or in Mississippi. No, it's not. It's corrected for patients who have the same kind of problem in the same city. So this is where we are going. This has happened in every other field except in medicine. Apologize for the slide just before lunch, but a lot of food and a lot of data both can have serious consequences. And just like food, you need to digest the data, assimilate it, and come up with useful information. So I'm going to take you back another about 150 years. And what you see is a map of London. This is Soho, London. The physician up there is John Snow. And London was in the gripes of a very severe cholera epidemic where there's large amount of stool, bowel movement loss and loss of fluids from vomiting. And the families could see each other dehydrate and die right in front of their eyes. Almost 10% of the population was decimated. John Snow had postulated a couple of years ago that this was caused by infection, contamination of water with feces. This was not acceptable to the Victorian mind at that time. he was treating these patients, and what you can see in the map in the inset is the number of deaths. So they are stacked up. So he painstakingly went from house to house and looked at the deaths. And when he presented this data, the authorities still didn't believe him. The red dot over there represents the Broadway pump from which the people would pump water from. And they did not believe him, but the evidence was so powerful, they removed the handle of the pump. The pump is no longer there. You see a pink tile over there. I actually visited this place. Now, wasn't this a fascinating display of business intelligence? Data collection, aggregation, display, visual display, inducing action and changing beliefs and practices forever. So like we heard some of the speakers say, the data doesn't have to be big, the impact has to be big. We are using similar kinds of approaches at Phoenix Children's Hospital, harnessing data from our electronic medical record. What you see over there is a normal intravenous IV in an infant. If the fluids leak out of that, you get swelling, and this is what it looks, and it should not look like this. And if some of those fluids are caustic, you can get burns like this. We definitely don't want this to happen. So we have developed predictive analytic algorithms to kind of do early warning against this and to pick up those children who could be at risk for this, send a text message to the nurses who can address this earlier. Moving on, the e-health revolution is also occurring in the developing world. That's not immune, it's happening in a different way. Their challenges are different. Here we encourage, with a sedentary lifestyle, you encourage walking. There, walking is not a problem. You have to walk miles to get water, heavy water on your head. So invention is in a different way. It's actually reinventing the wheel. So this is providing an easy way to move water. So different problems, different challenges, not all have to be digital. What's a Ziploc bag to do with incubators? Well, when you don't have enough expensive incubators for your premature patients, a Ziploc bag can provide some amount of warmth and humidity. So again, different challenges, different resolutions, different ideas, and different innovations. So we have taken a snapshot view of various aspects of healthcare disruption in healthcare technology. How do you put it all together? Where do you go from here? And I think Wayne Gretzky said it best, one of the best ice hockey players, that a good player is where the puck is, and a great player is where the puck is going to be. So where's your healthcare puck going to be? And these are the 4 areas that we covered. Unlike various other industries, you see similar patterns. It's going to be mobile, it's going to be social, it's going to be patient-centric. It's no longer going to be driven by physicians. The patients are the consumers who are going to demand and drive the change. And innovation and data is going to be the center of it all. Your support is important for making this happen. The communications, the network, the storage, the application development. But it has to be medical grade. Good is not good enough. If your cable is out, you miss a movie. If your phone network is out, you miss a text. If your pacemaker is out, you miss a beat, right? And if you miss a couple of beats, that's called cardiac arrest. So those kinds of things. And again, the direct connection between the patients, the consumers, the innovators, and the disruptors is going to be what is different in the last 50 years. So we often say that, is the doctor going to be obsolete? And the answer is no, unless you are on the left-hand side and you refuse change. We are going to see an evolution of a new healthcare physician in a new role who is going to be the knowledge engineer with the patient at the center. Healthcare is more than just ones and zeros and the genetic 6 billion codes. It is a sector which gets you closer to humanity than any other sector. It's the human touch that matters. I experience that every day, and I love what I'm doing. So I often get asked, in conclusion, that with all this e-health going on, is paper going to go away? Is the doctor going to be sidetracked? And I say, don't worry, paper is not going to go away. It will still have some really very important uses. I'm going to conclude by quoting a quote that I like a lot. A man never stands as tall as when he kneels to help a child. That's our philosophy, and it is the children that drive what we are doing. Thank you.
Thanks. Doc, have a seat. We're not going to let you get away that easy. People are still trying to get their stomachs back for lunch, I think, so we might have to give them a bit of a moment to recover.
Sure.
How did the hand work out, by the way? Is it okay?
Yeah, it's fine. I can use the keyboard and the mouse pretty well.
I really, now you're a doctor, right? You're a medical doctor.
That's right.
So
A real one.
A real one. But how did you get into the information field and the digital information field?
Yes, it's a very interesting question, and Tony, I alluded a little bit to it, but to give more details, as an intensive care physician, I would take care of one patient at a time, take care of a unit with 20 patients, and it was really gratifying saving lives, talking to families, helping them out. But I quickly realized that I was limited by what I could do one-on-one. And through information technology, I could reach out to many more. So we are reaching out to patients whom I have never seen. And I realized how far behind. We were kind of in stone ages, Tony.
Right.
So I think what was needed, it was the right time, and I'm seeing what is happening in the hospital with the tools that we are using.
Well, you're talking about the tools that they're using. You know, there are all sort of exciting things going on in the healthcare system, not just here, but worldwide. How are physicians embracing this change? And is it something they're embracing readily, or are they sort of being dragged in? We've got probably the old school medico that probably isn't too keen on some of this.
I'm going to hesitate in answering that.
I know it's a tough question for you.
Well, it's...
Firstly, are there any doctors in the room? You're okay. You can now go ahead.
Like I often say, life is a bell-shaped curve. You have your early adopters, the big majority, and then the laggards. And it is no secret that the healthcare industry has been far behind every other industry. But there's clearly a group of us who see the direction, who see what transformation this can bring. And the others are a little cautious, and caution is okay, because you don't want to rush. You don't want to, pick up the next most popular thing and then find out it doesn't work. So I think we need all kinds, but I must say that it's funny, Tony, I was talking to one of the physicians, and we had an interaction about using a software. And he said, 3 times you said right click. What is right click?
Oh, so, no.
Well, not everybody is that way, but yeah, it's a tough area to get change into.
Well, I don't mind doctors being cautious. I think that's a good trait for a doctor. Sure. But you mentioned patients are taking more and more active role in managing their own health. Do you see the danger of a do-it-yourself mentality occurring, and will doctors be sidetracked as a result of that?
To every new change, there is a positive and negative side. And I think what will emerge is what's the best way of doing things. So if you swing the pendulum in either direction, we started with a paternalistic physician society where the physician knows best. And you stay away, I'll let you know what to do, and I'll take care of you. And now we are seeing the pendulum moving to the center. There is definitely a risk, and we heard from some of the speakers, going onto the internet and changing your doctors until you find the one who makes the right. So I can easily see that the pendulum could swing, but I think it will find its happy medium.
Okay, well, what do you think needs to happen next for this revolution to continue, both from the medical side and the doctors getting on board, and for the customers, the consumers being more careful? What's the next area? What's the next position?
And we have seen those themes being discussed here. We have seen and shown the early advantages gained. We need to consolidate that, and I really think that mobile, social, analytics, security are the 4 pillars on which the healthcare revolution is going to really take off.
And will it be led by the United States, do you think?
No, it's a global world.
It is.
It's a global world, and the ideas are going to spring from everywhere. So
we just have to be open for them.
Absolutely.
Doctor?
Tony, I have just one thing for you. I was checking my smartphone, and I put in your profile, and it came up with a diagnosis.
Oh no, it's a bad one, I know.
You're suffering from stage fright.
Yes, I have a real problem with it. On that note, thank you very much, Doc. Thanks very much. Thank you. I wish all doctors in the world were like that. Very easy to talk to and a great presentation. Those of you that are left, I hope you've still got a stomach for lunch, because there's lots of it out there. It's being served in Hall 1. Don't forget the TM Forum Zone is open. All the things that have been discussed in here and the areas that we're covering in the conference will all be demonstrated. We have over, I think, 10 catalysts this year to go through. The only thing I would ask you now is to move pretty quickly out of the room, because we have to completely change this back into the rooms for the next session. So thank you all, and thanks to all our speakers today. Thank you.